Welcome to Public Health on Call, a new podcast from the Johns Hopkins Bloomberg School of Public Health. Our focus is the novel coronavirus. I'm Josh Sharfstein, a faculty member at Johns Hopkins and also a former secretary of Maryland's Health Department. Our goal with this podcast is to bring evidence and experts to help you understand today's news about the novel coronavirus and what it means for tomorrow. If you have questions, you can email them to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, Stephanie Desmond speaks to Dr. Rick Redett, a pediatric plastic surgeon at Johns Hopkins. When the governor of Maryland ordered the end of elective surgery 2 months ago, Dr. Redett volunteered to work in the adult intensive care unit for COVID-19 patients. He talks to Stephanie about the experience. Let's listen.
Thanks so much for joining me.
Thank you for having me.
So, Rick, tell me a little bit about what your day job is at Johns Hopkins Hospital.
Well, my day job's a little different now than it used to be, but prior to the pandemic, I was, and I still am, a pediatric plastic surgeon. What that means is I take care of kids with facial differences, from cleft lip and palate to other craniofacial anomalies. I take care of pediatric burn patients, and I take care of kids with pediatric hand problems. I'm also the interim director of the Department of Plastic and Reconstructive Surgery at Johns Hopkins.
So, about 2 months ago, early March, I guess Johns Hopkins stopped doing what's considered elective surgeries, and your surgeries were considered elective.
Most of my surgeries are elective. I do burn surgery, and that's not elective, but probably 90 or even 95% of my practice is elective, which to us means scheduled ahead of time.
Mm-hmm. Not necessarily something we would all choose to have, of course, but again, scheduled ahead of time. And I understand that the hospital shut down elective surgeries because of the pandemic, because of the need for beds.
Right. About 2 months ago, when COVID became a problem in Maryland, we stopped doing elective surgery, and we did that to preserve resources. And resources in a hospital are beds and staff and PPEs that everyone's heard about.
Mm-hmm. So instead of doing nothing, what did you decide to do?
Well,
And how did you come to the decision?
the hospital sent out a request for faculty and staff and residents to be redeployed. And what that means is leaving your current position and doing something else. And as an interim director and being put in the position where I would have to ask my faculty and staff to be redeployed, I thought it was very important that I lead by example and redeploy myself. In addition to that, I just really wanted to help out.
Mm-hmm. And so where were you redeployed?
I was redeployed to one of the adult COVID ICUs on one of our floors called Nelson 5. So I went from being a pediatric plastic surgeon to being an adult ICU COVID doctor. And I hadn't done that in a while, so it was a big learning experience for me, but overall, a great experience for me.
Mm-hmm. So they put you right in there. I mean, they had you working with COVID patients.
They did. They had me working with COVID patients, and more importantly, they had me working with some other very good adult COVID doctors,
Yeah.
Residents, fellows, and attendings.
Mm-hmm. I guess this meant 12-hour shifts in the ICU and probably some muscles you had not exercised in a while.
Yeah, they were 12-hour shifts. I'm very used to operating for 12 hours at a time, and I can leave the OR after 12 hours and feel pretty good and pretty rested because it's what I do every day, and I've done it for 20 plus years. But I have to say those ICU shifts were pretty exhausting, and I think it was primarily due to the fact that I had to use, as you said, many muscles I hadn't used before, and primarily just a lot of terminology and ICU care that I haven't done in many, many years.
Mm-hmm.
So it took a lot of work for me.
Yeah. So were these things you'd never done before, or had you?
Not really never done before. When I trained, we did a lot of ICU work as a general surgery resident. So I've done it before, but it's changed a lot. And a lot of the acronyms have changed. So I found myself asking a lot of questions and looking a lot of those acronyms up. I had done a lot of it before, but it had been a long time. So it took a lot of work to get up to speed.
Mm-hmm. So Were there a lot of other people in your boat, or were you was you and the folks who had this experience?
No, there were a lot of other people in a similar boat. Our team had a urology resident, a psychiatry resident, a cardiology resident, and some medical residents. So people from all different departments were volunteering to be redeployed.
Hmm. When they said you were going to work with COVID patients, were you nervous? I mean, that's we don't know much about COVID even now.
I was a little nervous, but the hospital has done such a great job of providing PPE for faculty and staff that I felt very good and I felt very protected going into the units. And I think my 3 week experience there, I think most of what I saw was everyone else kind of feeling the same. The PPEs are good, they're more than adequate, and people feel generally pretty safe taking care of the patients.
Hmm. Tell me about the patients you saw in the ICU. I mean, this is a different disease than we've seen before.
It is. And as you've read in the media, many of the patients are older and they have a lot of other medical problems. But you do see younger patients that don't have so many medical problems. But again, most of the time they're a minority.
Hmm. Hmm. And would you say, I guess it was also an unusual experience because there's no visitors allowed, and these are very sick people who didn't have their support systems.
That's correct. The hospital will make an occasional exception if a patient is nearing the end of life, and they will let an occasional family member visit that patient. But in general, the patients don't have visitors. So it's kind of a sad thing to watch somebody go through.
Hmm. I guess you learned a lot about the disease every day.
I did. I redeployed, but there are people that are doing this for a living, doctors and nurses and techs, and they taught me a lot when I was in the ICU. And everyone's kind of learning how to take care of these patients together. It's a new disease, and nobody has a great understanding of it. So everyone's working together to solve these very difficult problems. And as I've said before, I think that's one of the great things we do at Hopkins or in medicine in general. We get together and we collaborate to solve some of our patients' most difficult problems.
Hmm. Hmm. Did you feel like, I mean, there's no real standard of treatment at this point. There's no vaccine. There's no magic bullet pill. Did that feel frustrating to you as a doctor?
It is frustrating. As a surgeon, you're used to a very definitive solution to solve a problem, especially as a pediatric plastic surgeon. That almost every patient I operate on, I have a solution to their problem. And when you're taking care of COVID patients, most of the care you provide is supportive. You don't necessarily have a cure, but you support them through the disease process by supporting the different organs and the different bodily systems.
Hmm. I guess it really probably changed your perspective a little.
It did. It made me very grateful for what I do during my day job. But it also was very heartwarming for me to see everyone come together and work as hard as they are to care for these patients. And, at Hopkins, we're on the front line of innovative care, and you see new treatments and new care literally unfold before your eyes when you're taking care of these patients.
Hmm. Hmm. So now that you're back to your surgical job, I'm wondering if things are different now.
Well, things are a little different. The governor has given us the go ahead to start doing elective surgeries in an outpatient setting, and our department started that this week. So we're slowly ramping up our surgical practice, and we're beginning to see patients in person in clinic again.
Hmm.
And it's been, gosh, probably a solid 2 months since we've done that. So everyone's quite excited to get back to work.
Like that. And I also imagine the patients who were supposed to be getting their elective surgery are pretty excited, or at least their parents are pretty excited that you're going to be able to move forward.
They are. I mean, we were very careful to not delay any surgery that we thought had to be done, but we delayed a lot of our elective practice, and we're
Mhm.
starting to ramp that up again. And families and patients are very happy to come in and have their problems taken care of.
Mhm. What do you think you'll take away from this entire experience?
Well, I'm not sure yet. I mean, there are a lot of things I'll take away from it. One is just seeing how people come together to care for these patients. I think that's just a great and very heartwarming, as I said earlier, heartwarming thing to see. And it's also a new disease, and we're learning how to care for these patients minute by minute and day to day. And I don't think many of us have an opportunity to see that in a lifetime. And with coronavirus or COVID-19, we're kind of living through that right now. We're learning how to care for these patients. We're learning how to treat these patients because it's a very new disease.
Mm-hmm. Rick Radet, thank you so much for joining me.
Thank you for having me.
Thank you for listening to Public Health on Call, a new podcast from the Johns Hopkins Bloomberg School of Public Health. Please send questions to be covered in future podcasts to publichealthquestion@jhu.edu. This podcast is produced by Josh Sharfstein, Lindsay Smith-Rogers, and Lamare Morales. Audio production by Niall Owen McCusker and Spencer Greer, with support from Chip Hickey. Distribution by Nick Moran. Thank you for listening.